Patient's having symptoms at home.
Mhm.
Somebody's rushing them to the hospital.
Correct.
When they hit that ER door, what should happen? What should they say? What are they gonna go through?
Yeah, so they can come into the hospital by one of 2 ways. They can come in by private auto. So somebody from their family drives them into the hospital, and they present through triage. We have nurses in triage, and we also have PAs and NPs in triage that can recognize some of these symptoms, and they will activate a code stroke. The other way is if they call 911 and they're brought in by ambulance, those paramedics actually communicate to the nurses at the hospital via radio any symptoms that are alluding to a stroke. So they can come in by 2 mechanisms. Once that code stroke is activated, that prompts my presence there at the patient's bedside. From then, I start my assessment using the NIH stroke scale. So we do a list of things. And the way that is it's cumulative. So the higher the number on the NIH stroke scale, basically the more debilitating factors I've encountered. And so we're tallying it up. So for maybe slurred speech, that's a point right there. Maybe 2 points if you can't, intelligibly understand what they're saying. They are so dysarthric. That's a 2. So it just kind of tallies up from there. Then I start to ask them questions that would exclude them from being a candidate for TNK. Have they had a recent stroke within the past 3 months? Have they had a head injury? Have they had any cancerous lesions in the brain? Things that would rule them out for getting the TNK. Once they are ruled in and they're within that 4.5-hour window, we take them quickly to CT scan because the number one thing I want to see on a head CT is that there's no blood in the brain. If they're bleeding, all bets are off. We can't give them TNK. But if they're within that 4.5-hour window, they have debilitating symptoms, and there's a negative head CT, then we can give the TNK. And we try to give it in 20 minutes or less.
And if, say, for example, if a patient gets to the hospital within 4.5 hours
Mhm.
and they can't get TNK because, I don't know, say there's a malignancy, or
Okay.
say there's some other thing, I don't know.
Mhm.
Are there other options for them after you've ruled out an acute bleed? Are there other
Yeah.
options?
Yeah, there is. So that would be a situation, or let's just say they had the symptoms, but they're now beyond the 4.5-hour window, but less than 24 hours, we can do something called a mechanical thrombectomy. I work for a neurointerventional radiologist, and he's the one who performs these. So I just help coordinate these procedures. I recognize the symptoms, activate a code fast. And so what that means is we'll bring them down to the NIR suite where we have fluoroscopy and different imaging available. Then we prep the patient for the mechanical thrombectomy. What that entails is accessing the groin, going all the way up past the heart, basically kind of scooting our way through the vessels. And we make our way to the occlusion where we can mechanically remove the the insulting occlusion that is causing all of these debilitating symptoms.
And that's a pretty successful procedure, yeah?
It's a pretty successful procedure, and the benefit highly outweighs the risk. Of course, with any procedure in the hospital, there's always associated risk, infection, bleeding. We're working with the vessels, so dissection. We talk to the patients about that if we can, if they're consentable, and we talk to them about these. But again, the benefit highly outweighs the risk.